Good. How are you? It's
Mm.
Friday. We weren't planning on doing anything this week, but
Sure we were. We just didn't know it.
this I wrote something and then suddenly we decided it was time.
It
There you
is.
go. All right. Welcome to Food is Health Live for anyone that's new here. So, let's talk about why we went live today or what we're going live about, since, as you just said,
You went viral. You went viral.
right.
You
We
went
went
like
viral.
you wet market viral.
I don't know what's viral. I did see on LinkedIn's account, from LinkedIn's perspective, I think it's like 100,000 impressions. And I'm still a little bit shy of that, but I'm darn close. But joking aside, so I think what's interesting here is a lot of people would be celebrating that they went viral because it somehow means something about people knowing about them, and that is not the novelty here. I think the novelty is what went viral and why it went viral and digging into it, because I think we both, when I first saw it pick up steam yesterday, I called you and I said, there's something here. So, do we want to?
Why don't you tell people what it is?
Well, it would probably be even easier if I just shared my screen,
Shared your
right?
screen.
Well, first there was a post. So I think the probably give a little context, which is I try on the Substack to on Wednesdays do a more personal health post, but in a frame of mind from an operator's lens. So whether you're in the healthcare industry, whether you're in the food industry, ag industry, whatever, of course, all of these have the same road leading back to human health, but somehow we've forgotten that fact. And I try to write something because I am the ultimate early adopter. Lots of people have lots of names for me of what I fall into, but I kind of throw everything at myself to learn it, to understand it when it comes to health. And so I have been long overdue in posting this comparison chart that I put together for myself months ago of all of the quote unquote comprehensive preventative diagnostic lab testing companies that are out there. And so I decided Wednesday I would write an article about this for the Substack, which I did. And then I decided that for this particular one, it would be good for the healthcare audience that I have over on LinkedIn to post the chart. And I wasn't expecting what happened when I posted the chart. So here's the post. And I am actually really excited to for us to sort of dive into the whole thing. And I want to go into all right, let me share my screen.
I think we
And I'm
yeah.
sorry if
Let me
anyone's
just give
making any comments on the Substack right now. I haven't pulled up the comment section, but all right, so here's the post. And let me make it a little bit bigger. See it
yeah.
okay?
So this is a no, you can't see it that well, but so it is a post comparing function, superhuman, all the different tests, lab test people against what they test.
Correct.
It's impossible to read the text, but and then if you scroll
Well, I'm going
down,
to open up a
just
version
scroll
of
down a little
this.
bit. Scroll down a little bit so we can see your numbers. So
That's the
90,000
number.
impressions in 24 hours. So which is high. It's not normal, and 72 comments. And then if you read through the comments, they're all substantive. So anybody, I don't know if you, no, we can't. Can we share in the chat?
I
I don't
can.
know.
I'm going to share the comments.
So if you go to Ellen's, you should go read the comments yourself. But if you go to Ellen's profile and look at the second, there are two posts. One was
So
the
I'm going to go
initial
back to the
post
beginning. We're going
that
to
did not
go.
get a lot of traction, and then you did a second version of it that did.
Which that was just fascinating in its own right.
Yes, but let's not worry about that. Let's what we
Okay,
got here in terms of comments
here's what we got.
ranged from doctors saying this is great to doctors saying this is going to lead to a lot of false positives and it's a waste of resources, to consumers and patients saying this is great, to CEOs of some of these companies. So these are the functions and the superhuman, saying we got the numbers wrong and we left something out. It was basically a chart of what's included in their tests. What else did we get in sort of the comments?
Well,
I haven't had a
yeah.
chance to
So
read
I
through
mean,
all.
no, but I think I think there's something beneficial about scrolling through these.
Yeah, let's dive. I wouldn't mind if we dove into some of them
Let's do it.
and
And
explain some of them.
I do want everybody to know that I am going to share an updated version of the chart. I have corrected, there's a couple of points made about, this is right or this is wrong or whatever. The good news is that didn't distract people. And I said in the beginning, like, I'm sure there are errors here. I have corrected a good part of it. And there were some interesting learnings when I did that and went in as deep as I did. I mean, I had done this chart a while ago and then updated it, but I really went in and dug deep in the last 24 hours. And I will pull that up just for anybody that's like, where's the new chart? I will share that shortly, but I want to jump in. Okay. So let's jump into these.
Can I jump into the punchline at the end of the day?
Sure, you can land the plane before we've even tried to fly it. Go for it.
Well, I can at least give a destination. The cost of you running your own assays on your body to understand what's going on is going to zero.
Yes.
It's not going to stop. A bunch of people who are in the healthcare field and other fields think it should stop. It's like Anthropic saying, stop AI so that we can make sure you don't use it wrong. And China releases 5 open weights models the next day that jump ahead. It's not going to stop. The ability to have tests, there was a debate on X the other day where a bunch of people said, oh, these MRIs are too expensive. People are wasting their money. Their money would be better spent elsewhere. There is technology coming out of Stanford University right now that's going to lower the cost of MRIs to $200 or $300 a person per scan, full body. Right now, that's $3,000, $3,500. When it's $200, are the same doctors going to say it's too expensive? Are the same healthcare professionals going to say it's too expensive? I don't know. And it really doesn't matter because consumers will make this decision on their own. And we're going to learn something. The second point of this is we have a huge array of 6-person data. We don't have much data on well people data. And if you're going to do any statistical analysis or you're going to really feed AI or you're going to feed any diagnostic tool, if you're going to build a good diagnostic tool, you need to have true positive data and false positive data and false negative data. You need all of that to get the filters and to work correctly. And so the sooner we can get enough people in there to take and have false positive data and fill the data sets with it, the sooner we're going to be in a position where the cost of this collapses and the fear of, oh, I'm getting a bunch of false positives goes away.
Agreed.
So that's my TLDR. But let's dive in.
Said as a true engineer.
True. Yes, I'm terribly insensitive to the fact if
I
somebody gets a test, thinks they has cancer, and then can't sleep for months because of it until they get the answer.
Just for the record, like before I met you, I admittedly didn't even know what a TLDR was. So I'm just saying that out loud.
Okay. Good to know.
Yes, I was trying to get into so I got a here we go. Can I watch this thing? I don't know. I'm trying to get into the comments in case people drop comments into the LinkedIn. I don't exactly know how to do that, but whatever. If I'm watching over on the food is health Substack. So I did get a text. That's what made me think of the comments. Is so Josh Marino says, Also for your chart, it would be fun to connect those markers to validate. So this is, Carter, what you and I were talking about this morning, which is creating this interactive chart. So, okay, let me back up. I'm getting all excited here. There's too much coming at me. This is the chart. This is an updated version of the chart, just so everybody knows. I had intended to have it completely done and published. I am still working through it, and there are some new columns that I want to decide which columns we're going to add, Carter, based on some new entrants that people responded. When we go through the comments, we're going to see this, the comments from LinkedIn. There are some things that I don't have on here, like other options that we weren't looking at, and I thought it'd be fun to actually look at some of them live while we go through this, so people understand. I have just been blown away at the number of people that this was eye-opening for them. Like, I've been following this, I've been tracking this. This wasn't particularly novel to me. And I think what it's making me realize is, A, there's a tremendous amount of latent demand. B, there's a raging debate, and it's very clear why. And then, which is very much in line with the work that we're doing and what we've built. But then C, it's also just indicative of, like, it's a new market. It's an emerging market. And, here we go. So here's the deal, right? I just want to walk through this chart for a second as we then bump into like comments, and we'll go into the other comments. But this chart, just so everybody's 100% clear, this chart was not designed as this is what we should be measuring. This chart was designed to make the point, which is, now that consumers have the ability to get the labs that they want without going to a doctor through these various options, and we're talking about, there's kind of three buckets here, that it has created a whole different unlock of agency and transparency. It has also created a new variation on the theme of the black box with some of these other newer companies. And it's a race to the bottom, to your point of it's going to be $0. And so what a lot of people have said to me even offline is like, wow, I didn't realize how inexpensive these have become. So just so everybody knows, like, if you really want to kind of baseline this to a comprehensive panel, I mean, it's already at a point where you pretty much get a comprehensive panel for like $150. That's what this pretty much comes at. And I would say Good Labs, which was somebody that's just recently hit my radar, thanks to actually a social friend. I was unaware of them professionally. Good Labs now has a panel that competes with Superpower, for example, that is $75 cheaper. So if you just want to get a whole bunch of data on yourself, I would say from a value perspective, a good starting point here is probably Good Labs. Function is the one that most people are the most aware of. It's $365 for the year, and you get 2 tests. But here's what's really interesting, Carter, and this is what I kind of dug into, is you don't get 2 full tests. You get 1 comprehensive test, and then you get a follow-up test that includes certain markers. And so that's what this chart now says, is like, here's a check mark for all the things you get on your test. And then when it says 2x, that's what you're getting your follow-up test on, just so people kind of understand this. And then Superpower directly competes with Function Health. They don't have the same number of add-on tests. That's the other thing that I'm going to add to this chart, is there's a whole slew of add-on tests that I didn't include in the base that I'm going to add on to this. I'm not going to go into all the details, but just sort of their general groupings. The other thing that's really interesting here is, like, the biomarker is like a total marketing claim. So when you dig in, Function, for example, they actually say 160. But the truth is that they don't measure 160. They calculate a whole bunch of the 160. So most of these are only getting between 50 and 100 actual metrics, and then they're calculating based on the lab data what these other markers are, and then they're creating also things that are done by algorithms. So for example, each of them, like Function, Superpower, they've got their own proprietary algorithm of your biological age. And they're just basically taking certain things from your lab data and then comparing you each of those things against the reference range of the general population, and then they're sort of inferring what does this mean to potential future state of your health versus where you should be, and then giving it a weighting by grouping and coming up with this magical age. So it's all, again, it's like a new type of black box. And then you've got a couple of competitors that, in my opinion, are the most interesting in this, which is Aura and Ultrahuman, which is they have the commoditized labs that they've added on to hardware and an ecosystem that they're attempting to build. And to me, that's actually a lot more interesting than, to some extent, Function and Superpower, because they've already built their own version of a healthcare delivery system with their hardware versus Function and Superpower, where they're great comprehensive tests. There's a lot of algorithms of trying to help you navigate that data. They're trying to build a healthcare ecosystem around that, and then they're allowing you to plug your wearables.
Well, so were any comments in the thread? So we're sort of trying to figure out why people gravitated to this thread.
Well, so let's go over to the thread. I hear you. Like, I'll stop talking about the chart.
Well, no, but question is, are people doing these tests to then get clinical validation or clinical action? So to some degree, when this all started and Function Health started, someone reminded us that if the original value proposition of Function was, if you try to get all these tests yourself, you're going to pay $5,000. We've bundled them together.
Yep.
So that you can get it for $400. And so for worried well that wanted to get these tests or whatever, that was sort of cool. It's sort of the biohacker crowd. But now, pretty quickly, Quest and LabCorp are like, look, we can run these tests in a whole bunch of different ways, and we have multi-omic scanners that do this stuff. So it's almost free for us to do these tests. Not exactly, but it's fairly simple for us to do these tests. So we'll do it. So now others have emerged. So then what's the question? What's the business model? So if you're sitting inside Function Health and deciding what your business model is, you started this thing, as we say, from the okay, we're going to lower costs for people. But now all the costs are going down. So then the question is does it drive care? Is this a precursor? Do you do these tests on your own and go see your doctor? Does your doctor say, I can't get these tests for you, go pay cash? Do people do these tests and never see their doctor? There's a whole range of what happens next. And then does it matter? Should I do it? I did these tests. I do these tests on a regular basis, and I did my regular Function Health tests. And it showed I had a PSA of 4.1, which was, my last one was like 280 or something like that, or 3. And at my age, 4.1 is not good. So, but I also had done that after a long car trip, sitting on my ass for 12 hours. And so
a bike ride. I've talked about this. My father has a horrible time with PSA with his doctor. He's 80 though, and it is directly correlated to how much he's riding his bike.
So I did a one-off PSA test 2 weeks later at $60 that I ordered direct out of Quest, and I now see you can do a PSA on these other services for like 30. I was worried for 2 weeks, and then anyway, got on the other side. PSA was sort of generally back to normal, 3.2. So I'll go see still a urologist about it. I just haven't scheduled that, and he'll tell me probably it's nothing. So false positive, worried, spent 2 weeks worried about it, sort of. And I don't know what I've learned, but
well, why haven't you scheduled your appointment yet?
Oh, I'm lazy.
But okay, let's talk about that for a minute. It's not that you're lazy. If you were truly, truly concerned, you would have scheduled an appointment, no?
That's true. So now I haven't bothered the urologists.
Because you think it's a false positive.
I think it's a false positive.
Well, so let's go into the comments here. There's some really interesting ones because there's actually somebody got pretty passionate about the false positive side. But let's just start from the beginning. Let's jump through this. So we've got I don't understand why LinkedIn does this sometimes. We've got our buddy Peter. So Peter kicked off everything with this comment, which I think is also rather fitting. So he's been very, very vocal with us and about System C and our construct, and he's been working at this for a long time as well. And System C being the best of inherent health combined with scaling, right? From all the way from soil to food to health. So it's an economy around human outcomes, around health, which we believe exists. It just hasn't been sort of put in, hasn't been priced correctly yet, symboled correctly. And, he makes the point in a different way than we do of GLP-1s plus blood work will actually become System C.
Is that just a statement or what is that?
So I said, if only it were that simple. And Peter actually did respond. Peter actually did respond and say, I swear he responded and now it's gone. But, his point was like, that's going to fix it. And I do think that that's this accelerating force that you and I have talked about. Is that they've
huge accelerant,
right? I mean, you wrote about it. We published a piece about it this morning.
Yeah, it's
what was the fact that you shared about trizepatide?
That the two molecules, the GLP-1 molecules, are 3 times as much revenue as AI right now.
Yeah, but it's also the most. What isn't it the most?
So most profitable or most revenue of any drug ever in the face of the planet.
There you go.
Or why don't you tell me what it is that you're searching for?
What? Oh, the statement that I was going to make.
Yeah.
It was.
Or you said anyway.
Yeah, I mean, it's in our post today. It was the exact statement was that it has become. Where is the statement? Sam, now I'm trying to find it. It has now become the best-selling drug on earth. Trizepatide. I mean, what does that say? I mean, yeah, we could all point a finger and say that means people want the easy button, but then they're all going out getting function health tests. So
hold on a second. I'm sorry. Let me say it another way. When people were buying GLP-1 cash, $1,500 a month, it put a price on getting rid of obesity. Before that, we really didn't have a solid price to understand what are people willing to pay to get rid of obesity. We didn't have a market price. We had a Medicare price. We had a healthcare price. We had a CPG price.
Yep.
But we didn't have a consumer price. We probably had some studies that sort of bounced around. But all of a sudden, all those studies mean nothing until someone starts paying cash. Hayek said this a long time ago. Hayek said you cannot coordinate an economy based on expert opinion. An economy and the innovation in an economy and how an economy allocates its resources is based on price. And until you have a price signal for a thing that you want to do, you can't coordinate innovation to cause it to be solved. So when $1,500 was put on the table cash pay and I could get it and I could reasonably get it, like I didn't have to go through 50 gates. I just had to get my doctor to sign off on it. And then someone stepped in and acted as my doctor to sign off on it. So gates removed, $1,500. What happened? Went to 1,000 and then it went to 450. And now you can get it for $50 on Medicare. So the price came down. We have a price where we know what people are willing to pay. And now we're going to get an understanding of how many people will pay for obesity solutions at $1,500 a month how much will pay at $1,000 a month, how much will pay at $495 a month, and how much will people pay at $50 a month. Now we have a price elasticity curve. And now anybody who's got a solution that mimics GLP-1 has a market. They can come in and say, we can deliver GLP-1 like benefits with this other thing. Maybe it's exercise, maybe, but whatever. They know what the price point is. And that just, to his point, it opens it up. It could be the GLP-1s are like the PC Junior. I don't know if anybody remembers the PC Junior, but the PC Junior came out as like a more affordable way to buy a PC at the time, back in 1982, with a chiclet keyboard. Anyway, so you had the PC keyboard, PC Junior. We may get to a point that people realize there's a better thing. We're investing in a new company that's got a metabolite that it uses a different vector that is OTC and very much like GLP-1, but has its slightly different behavior.
I mean, we're going to have a whole, I mean, it's just like, okay, I'll use an analogy with that. So you're talking about the evolution of that. We were on a call just before this, which is why we started a minute or two late because I was scrambling. It was a fascinating conversation, which is why it went over. We were talking about MRIs, right? I mean, all of this, the price is just going to come down and the product is going to change, right? It's not necessarily going to be just a lower price for the exact same thing.
Yeah.
And so, I mean, all of this is going to change dramatically. Like the lab tests, perfect example. We're going to go through this when we go through the comments. We had a couple of companies respond to throw their hat in the ring to be part of this chart. And at least one, if not two of them, are actual like finger prick companies. So, you take a sample of your blood and it's like, you send the finger prick blood off to them. We'll look it up. But that's an example, right? Which is like, okay, you can do this version. You go to Quest, they draw your labs. I mean, I went yesterday. I was talking about this. I didn't have my big labs drawn, which is another story. It's fascinating how much agency we as consumers have now, if we want. And it's early innings. I mean, like, as we said in January, this is as bad as it gets. So it's fascinating what you can do now with all of this. Okay, so do we want to let's jump into let's take a couple minutes, go through some comments, and let's go back to the chart. Let's kind of bounce back and forth. And I know some people are in here just to look at the chart. Some people want to hear the debate. You and I want to unpack the whole thing. I'm really hoping that people put some comments in here so that there's a little bit more of a discussion. I know one of the clinicians that weighed in here, she might jump on. She had a conflict. I think she's going to try to be around, so we'll see. But so this was where the clinical dialogue started. And just so everybody knows, the piece that I wrote in the Substack on Wednesday outlined the debate that we are seeing in healthcare around these tests, which is healthcare has very much been designed around acute care, around treating disease once it's established, around prevention being vaccines, a visit, very simple, right? You don't do much until something happens. That's the way healthcare is designed. It's how the economics behind it are aligned. Everything about it is set up that way. And this is a whole different approach. And so what we're seeing is a very vocal dissension and sort of debate within healthcare of when people put their clinician hats on and they look at the training that they've had and they look at the reimbursement that they can get and they look at the financial impact that care consumed, care delivered has on the medical complex, on the healthcare complex. They're very focused on necessity. And so prevention, primary prevention, as I always say, happens in the grocery store, but we don't deliver it. So then it falls to healthcare. Primary prevention is not insurable downstream. the impacts of whether or not you had primary, you know, prevention are priced downstream. There's nothing upstream around that. So, and this is entirely, you know, prevention. Now you've hit on a couple that's the first tier, but the second tier of people doing this, and arguably it's the other way around. We have a big bucket of folks that, well, maybe that's what we should do, Carter. Maybe we should bucket. Let me kind of throw 3 buckets of people that I think are really moving this early adopter curve up more. I think we've got millions of people that are uninsured. And so they're trying to figure out how to get their arms around their health since they don't have insurance. And I think that chart is a perfect example of where they're gravitating, because they're like, okay, I'm not paying for insurance anymore. I don't have it anymore. What's more valuable? Getting 160 biomarkers that I can feed into AI and get a whole bunch of information and decide whether or not I go to the doctor, right? And I pay $300 for the year or $400 for the year? Or do I spend $400 out of pocket for a visit and take what they tell me? Make sense?
Yep.
So that's a bucket, is the uninsured trying to create their own delivery system.
Do you think it's big, or
what's that? Oh, look.
Right. Uninsured or underinsured, or are they?
We have a guest. We have a special guest.
Hi, how are you?
Good. You joined us. I'm so glad you joined us.
I was listening for a little while, and I heard you mention me, so I thought I should jump on. But I am hearing some feedback because I think I have your LinkedIn thing open. So I'm going to close
Oh, okay. You just have to mute it.
Oh.
If you go over to that screen, there's like down the bottom, there's a speaker icon. Oh, you muted the wrong one.
Oh. Should I open it again? I just closed the tab.
If you close the tab, you should be okay. Are you still getting feedback?
I don't think so. The feedback that I'm hearing now was already on. I think there's something on one of yours. But it's not that much. It's very
okay. Yeah. So introduce yourself, and I'll go up to your comment, because this is okay. So I have the screen shared. I'm so excited that you were able to jump on. So here is the dialogue, your dialogue that prompted why I said you should jump on.
I know. I do things so differently, and I'll tell you why. I mean, that's part of my introduction. I'm actually board certified in emergency medicine, but when I did my lifestyle medicine board certification, and I started to actually think about problems differently, you know, I worked in the emergency department still. I never thought about switching out of it, but I would start asking people almost apologetically about their lifestyles, and they loved it. And I used to get asked at least once or twice a year, do you have your own practice? You know, like maybe I could see you. That's typical for every emergency medicine physician. But after I started doing lifestyle care in the emergency department, it was like at least once or twice a shift. And so I realized that there is a really important role that people can play as a clinician in people's lifestyles. Whereas some clinicians, and I've heard all kinds of things, where a lot of clinicians feel like it's not their role, right? They feel like they don't gatekeep lifestyles like they can pharmaceuticals, or like we're talking about today, labs. So when I decided to open my own lifestyle care, primary care practice, then it came to designing it. And the way I designed it is that I'm very data driven. I'm an MIT grad. For better or for worse, I need the data. I'm also an engineer. And so I need information. And what I found was that with all of that information at hand, I was really able to not only be more customized and you know, therapeutically beneficial to my patients in my recommendations, but also more convincing, because they see that I'm looking at their information. And I mentioned in these comments that I make an Excel spreadsheet for each patient, and they can see themselves what's happening when they make their own changes very easily with that spreadsheet. And so it becomes extremely beneficial for me to have all that information so that I could provide the care that I want to provide. And I do have discounts with labs so that I could get these labs done very
So
efficiently.
how does that? I'm sorry, you went from an hospital SER to now your own practice focused on functional or lifestyle.
I don't call myself functional. I think there's different
I
certifications.
didn't mean it. I
Oh,
didn't
no,
mean that. But
no,
your
no, I
lifestyle,
just wanted to clarify. Yeah,
yeah.
I'm lifestyle primary care.
And so, what's an example of a clinical situation that it helped?
Oh, so many. It's so many examples. Um, at the very basic level, everybody gets to understand how their own body reacts under different kinds of circumstances that they're putting themselves under, and they know they'll get that information, so they're more likely to actually do the things that I'm asking them to do so they can see if it was enough. So let me give you an example. A lot of times if somebody's um, you know, like these labs are the outcomes of little experiments that people want to be doing on themselves so that they can understand themselves. And the labs are the outcomes data. If you're doing it blindly and you don't have that outcomes data, then you don't get to modify how you're behaving, which is
Yeah,
why the glucose monitoring was so effective. It wasn't because a clinician got to see that data and review it with the patient. It's because the patient could see it in real time and actually modify their behavior almost immediately. So what happens with my practice, and I can show an example of my spreadsheets, but for example, in my personal spreadsheet, I got to actually check my labs after I started eating more dairy, more cheese. I love cheese. I know I'm not lifestyle medicine too, but it was my weakness. And I thought, like, let me see what it's doing to me then. And I could see that and then modify my behavior because I knew the change that I made in my lifestyle. And then that's going to have long-term impacts, drastic long-term impacts for me and my behavior. And if you think about it, people aren't used to that. They're not used to knowing how a certain lifestyle thing is actually impacting them. You talked about bike riding with PSA. So the correct way to understand that is to, and this is what I do with patients who are on creatine, is to get the labs when you are bike riding and get the labs when you're not bike riding. And that way, anytime you get labs, you have some baselines that you can compare to. And on my Excel spreadsheet, I would have written like bike riding immediately before and then bike riding immediately after. And now I have some baselines for you so that if I do have a lab level that's, for example, let's say it was 1 when you weren't and 2 when you were, then it becomes 4, which I know it wasn't the case, but I'm just saying now I can understand better what happened, right? And then you can give me your history. This is why, digital rectal exams, the same reason we were talking about bike riding, digital rectal exams have gone out of favor because right after they did the rectal exam, then they would check the labs during the physical, they would get the blood. And that's when the PSA is going to go high. And so they
yeah,
couldn't rely on the PSA. Like it's the same types of things. And if you look at what's happening around the labs, that context and the lifestyle context is so important. That's why I just like information like data. Now, we're not used to collecting that information as a whole, as physicians. And so I can understand when physicians aren't collecting that information, this data becomes just extra noise. They're not used to how to look at it from that perspective. Um, but that's why I actually really, really try to advocate for all those companies that are doing real world evidence. They're looking at each individual person's chart and they're looking at, what characteristics of that person made this therapy, like ibuprofen, much more effective for their headache versus this person was responding to Tylenol. They can do that now, but they're always looking at just pharmaceuticals instead of also adding in lifestyle. So there's an idea for a company is something that actually factors in all of that information. You don't have one company doing all of it together. You have Aura doing
Yeah.
one side of it. You have like apropos doing another side of it. You don't have anything doing it all together, which it needs to be all together because it's all health. It's all our health. We need to look at all of that.
And do your patients, your patients are probably paying out of pocket for some elements of this. What's your sense of the kind of patient, affluent, not affluent, have cash pay, are worried and will pay cash for anything? And how are they making sort of the economic decision here, or are they? Are you getting exposed to any of that?
I am, yeah. So I have all kinds of patients. Like you said, I have some of the top paid people in Connecticut with some certain, I don't know, positions high up. I don't want to mention anything specific. I have people that will never work a day in their life again, but then I have retired seniors on fixed incomes. I have police force, fire department, working teachers in public school systems, young people, old people, however you want to slice it. I have all of them because I don't charge a concierge rate. I just take insurance. But there are people who could pay the concierge rate that still come to me because of the way I'm looking at their data and it makes more sense to them. I have what's called a DPC hybrid practice. So I take insurance as well as have DPC rates for people who don't have insurance because there's a lot of people that fall through the cracks of the broken healthcare system.
So I'm going to pause there for just a second because
Yeah.
we do have a very big mix of informed consumers and then healthcare operators and food operators and ag operators. So anybody who's watching, DPC is direct primary care. So and that is a very, when I was talking before you jumped on, I was talking about how sort of these different markets are starting to form outside of the traditional, how we traditionally think of segmentation within insurance or within healthcare of the consumer. We have sort of different cohorts now forming. And one of the sort of newer pieces that has emerged is direct primary care, where because the payment model doesn't really support it the way we know it needs to be delivered, one of the outcomes of that has been this model of direct primary care, which is DPC. And employers, just so folks understand, it is a way for employers, for example, to prioritize primary care for their employees outside of insurance. So they can say, you know what, I am going to contract with a direct primary care, you know, physician or multiple physicians, or I'm going to give a stipend through the HS. There's different ways of structuring benefits so that an employee can access direct primary care outside of their traditional insurance, or it includes it or whatever. But again, it's a way to offer something that we think is important for people that the traditional healthcare design model doesn't really recognize.
The way I think of it is the reason why I implemented a DPC site is also because it aligns incentives really well. So you get a monthly fee. The healthier your patients are, the less work you have to do. And so that's like the best system, right? Because the patients want you to want them to be healthy versus the current system where it's the unhealthier the patients are, the more the people make, like the clinicians and the clinics make. Now, we don't want to believe that our clinicians are operating under any kind of incentives that are purely monetization focused, which they're not. I mean, in my experience, the people that are working in the systems have all had the right intentions. It's usually about the systems that they're working in, whether it's an electronic system, which I haven't met a single EHR that can do the things that I want it to do for my purposes, which is why I have to not only use an ONC certified EHR because I'm part of an ACO, but also I have to keep my own records outside of an EHR to do the things I want to do.
All right.
Going back to labs.
Circling back on some of these costs, are you finding that people of modest means are willing to pay $1,000 out of pocket over a year to get better handle on this? I mean, what's your sense of what the dynamic is?
Totally great question. What I found is that um, sometimes we can find the right billing codes to get this covered by insurance, not all the time. And so that's why some of my labs are staged. So I guess I like in the post, I don't order all of the thyroid ones all at once, but if something seemed abnormal, then I can go back and say, oh, this is like abnormal lab finding. And it's up to me what I consider as abnormal for my patient, right? Because it's my clinical judgment. And if they don't like my clinical judgment, they can take me out of their insurance plan. But the fact of the matter is my patients are better, they're healthier. And so I don't think I'm getting kicked out of any insurance plans anytime soon. They're on less medications, they're getting fewer surgeries, they're losing weight naturally. I mean, we talked about GLP-1s. I think I mean, we didn't, you did. But most of my patients also try to find me because they don't want to take medications. So how do we do that? And so
Yeah.
that's another reason why people try to find me. And so I think I'm lucky. My practice is called Lifestyle and Family Medicine. I'm lucky I get to practice with the certain cohort of patients that have trusted me with their health, and I'm able to see those kinds of outcomes. But it did take stepping outside the traditional framework of how we're trained, because we're trained to practice the way companies will cover our care. And sometimes the best thing for the patient, like you were talking about, prevention, is not necessarily going to be covered. So I just did whatever I needed to do to take care of my patients. And then what insurance doesn't cover, I never bill my patients for. I just say if it does cover it, that's fine. If it doesn't cover it, I'm not going to bill you for it. My physical, for example, is an hour long, and I have a step test that I do on my patients every physical. That's not covered by any insurance. I've never gotten cut pay for it. But that's super important for me because I want my patients to understand their cardiorespiratory fitness. How many times patients will say, I exercise, I do it, I walk, I do this, and I do that, but it's not enough for their cardiorespiratory health. And they get to see that using these kinds of parameters. And I do it every year so they can trend, okay, this year the efforts that I made are actually making a difference, right? And so they need that data, I need that data, so I do it.
And how many of your patients are on things like an Aura or a Garmin or a Whoop? And
To be honest, I don't try to review that information. If they are using it, they're using it for themselves. The most useful thing for me is the heart rate. So I have patients who have SVTs. I'm checking, like I'm asking them, can you
yeah,
check your monitor? Can you get a monitor? I have patients who have cryptogenic strokes, and so we don't know the cause of the stroke, but all their labs seem fine. So sometimes those kinds of things, the heart rate is really helpful.
are there
But I
any
love that
tool?
stuff. I love that data because the feedback to the patient is the most important thing, right? Because they can see directly what happened that they just did, but they're not going to remember the next time they see me in the office. But they can look at what they just did in their lifestyle that impacted what's actually showing up.
Well, no,
Do you
so sorry.
do you have other people on your team that sort of in tech we would call this customer success? Like, is somebody else on your team who is dealing with sort of these frictional elements of how people should walk them through the system or deal with some of these kinds of questions of, hey, I'm trying to change my own behavior and what other tools might be helpful? Is
So
that
behavior
something?
change is a whole science, and I think the reason why I got into this field in the first place is because I found that I had a certain tendency, personality that matched what people. I don't think all clinicians should be doing behavior change, by the way. I feel like if they did try, they might even make it worse. But for some reason, maybe growing up in my environment, I'm able to manage emotions, and that's what behavior change is. It's about managing emotions. The very first question I ask is, what are people's goals? Because if you're not able to speak to their health goals, and if they have no health goals, for example, then you cannot even start behavior change. And so these are questions and like managing emotions and things that we don't learn in medical school. And there are certain kinds of professions that maybe they don't need to know how to do this. But for me in primary care, this is what I value out of my relationship with my patients, is that I'm able to do that for them. They trust me. We have a great relationship. I actually don't have anyone else on my team. I have no receptionist, no staff. It's just me. My patients call me. In fact, the phone call I received earlier was a patient reaching out to me directly, and I'm going to call her back right after this. So I actually, that's like, I mean, I think you can do a lifestyle clinic with a team, but because that's the part that I enjoy so much, I have a whiteboard right behind my desk. The reason why I have a whiteboard is because I started doing lifestyle care in the emergency department, and I realized like I would erase the whiteboard that has like nurses' names, MD's names, what all that name, in order to illustrate my points, and it was working so much better. So when I started my clinic, this whiteboard has been here since day one, so I could explain things to my patient. And in fact, what's up there is something that I explained to my patient yesterday, and it helps. It helps a lot. So I really enjoy that part. I think I could have been a teacher in another life, but yeah, I think that's the reason why I don't have the staff. I think you could have the staff to help with that.
And where are you located?
I'm in North Haven, Connecticut.
You're where? I'm sorry.
In North Haven, it's by New Haven, Connecticut. I work at Yale too, so I have a shift at Yale tomorrow as well. But my clinic is not affiliated with any health system. It's a private practice, and it's right outside of New Haven, Connecticut.
So Andy Beckman has a question, our buddy from Garmin. He had a question around what kind of movement you prescribe.
Movement?
Mm-hmm.
Yeah, so movement is broken down into 4 categories. So there's cardiorespiratory aerobic, then there's strength fitness resistance training, there's flexibility, and then there's balance. And I've added sedentary time to my questionnaire because going from 0 to something is sometimes the highest yield and the most you're going to get. So starting from my questionnaire, what people are doing, and then going back to their health goals, very often people are like, I don't want cognitive decline. I don't want physical decline as I get older. I've added cognitive as well, but you've asked about movement specifically. Depending on what their labs are, right? Because I've trended their labs, depending on what their health goals are. And sometimes I'll ask them, is this also maybe a health goal that you have? Just to try to increase or get them to prioritize certain kinds of movements. If their goal was diet, then I'm not about to sit here and say, let's do all of this stuff on your movement. I don't just blanket recommend one thing to everybody. But if they're already doing some cardio, then I'll ask them to do strength training. If they're already doing strength training, then I'll say, like they're doing no cardio, then I'll tell them, your heart and your lungs need a workout as well. And it's not always enough with strength training. So we can look at that with your physical every year. If you're above average on your step test, then we don't have to talk about it. But as that number starts to decline as you get older, then maybe we'll start to talk about adding in some aerobic exercises. So it's really customized to each individual. I don't have a blanket thing. Flexibility and balance, same thing. If somebody's saying, well, my balance, is not there yet, then again, we do all of those things. And then sedentary time is a big one, right? So you could be like working out every single day and meet all of those metrics that we have in lifestyle medicine to recommend to people, but still be sedentary 8 hours a day. So I always collect that information and I always make the recommendation about, getting up every 20 to 30 minutes for at least 1 to 2 minutes, minimum 20 seconds at a timer if you want to, do something fun, walk outside, things like that. So at least they've heard the recommendation from me. I say things like sitting is the new smoking and things like that.
So, question. So, Mike Williams is, I would call, a super informed consumer.
Okay.
He has massively reversed his chronic disease pathway and just super engaged in, and there's just so many folks like this. And he's industry and consumer. Like, I don't want to make it seem like, but and I mean, everybody is to some degree, just not necessarily in the space of what we would consider food as health in those different sectors. But he had a kind of a comment, and I think that's why I put the spreadsheet up. You made a comment as well, but he said, as a whole, most consumers of these tests do not understand the results.
Right.
And I think you've hit on that. We've talked about it. I do want to say one of the things I hadn't hit on yet when you jumped on yet was that all of these guys have now pretty much when I dug into it in the last 24 hours, most of them now have a direct connect or a custom connect or an MCP into AI. So they have positioned themselves to, and I think this is super important, is that they've chosen to remove the friction for consumers because they know where consumers are going to go with the data, right? They know that consumers don't have a clinician attached to the test results. And so they're just upfront, handing this over. So I just say that, Mike, to you to say, I think that most consumers don't, but I think that's changing dramatically. I also think that part of what these companies are selling is an interpretation layer through their proprietary algorithms, their color coded systems. I mean, I can slap up. I was thinking about slapping up my superpower results from last year because it was meant to scare me, even though when you looked at the data, it wasn't scary at all, right? It's just the way that because they want me to buy supplements, that's part of their business model. And so I think consumers are starting to understand it more, but I do agree that still most people do not. So he said, how does the consumer determine what company they need to use? And are they getting correct information? Less expensive is not always best. And so,
Well, let me postulate something here, which it would be interesting to talk through. So if you sort of say, what we just heard was, this is really good to give people the kind of feedback they need to understand whether the things that they're doing make sense.
It's a feedback loop, 100%.
So if it's a feedback loop, it'd be interesting to know what doesn't have good feedback.
So you're talking about the feedback from their behavior, right? Or their medication that they started or whatever. This is why we get the labs. We need that information. So they have to have a place to put in what they're testing for. Like what do they test? Like,
well, so to give you an example that I've got. So I don't have non-fatty liver disease, but I have too much visceral fat.
Yep.
Now, I figured that out really through having a DEXA scan. I don't think many people have a DEXA scan. And it may have been just obvious by looking at other measures. But what I can't figure out is what in my behavior reduces my visceral fat. I mean, I understand, get your cortisol levels down. My cortisol levels are fine. And I don't know, you hear different things and just lose weight. Okay. So, but I am sort of focused on the fact that my inflammatory markers are higher than I want them to be. And it's likely more specifically because of visceral fat. But I've got zero feedback system that says changing your behavior here, reduce your visceral fat by a pound, keep doing it. Without going to get another DEXA scan, which is inconvenient.
Well, we do measure waist circumference. In my clinic, every year we measure the waist circumference, and we also do the hip circumference to get the waist to hip ratio. So all of my patients, that's how I know if they've gotten their physical, because sometimes I'll take vital signs during non-physicals, but when I see the waist circumference and hip circumference, I know that they got their annual physical that year. So so that's an easy way for you to just keep track of it. But in terms of the lifestyle thing, right? So like whatever you're doing, you might want to see a certain result, right? So you want to be this is the outcome, right? The physical and the labs associated with it, and the vital signs and the biometric data and all of that stuff associated with it is your outcome of your lifestyle and what's going on inside of you and the behaviors that you have. And that's the outcomes data that we need to keep tracking and then relay that back to the patient with that context that your information is telling me that you are very stressed, that something has to change, that this isn't going to sustain. This is the trend. If we don't change anything, it's going to keep going in that direction. So even if it's not abnormal yet, I am able to give patients that kind of information. And so that's what's really powerful about getting some of these labs. Now, some of these labs are on the list that you only need really once. And especially if it's not really abnormal, you don't need to get them all the time. And back to Mike's point too, I also think that there are people that maybe don't even want to know. In my practice, I see all kinds of people. And so some of them also, they don't really want to be the person that's interpreting everything for themselves. And I want those patients in my clinic. The high performers, they're great. They're going to take care of themselves. They're going to self-correct. You barely have to say a single thing to them. But because I can make such a big difference in other people's lives who have a lot of anxiety sometimes, or maybe they're
Yeah.
just not as health literate, and they wanted to know, but they don't know how to ask those questions.
How do you find those patients?
I make myself very accessible, and most of my patients are word of mouth now. So all those patients, they can tell their friends that this doctor is not going to just push a pill on you, and she's really nice, and you can ask her about whatever you want. And so it's not just the kind of, you get a lot of people that. So for me, a lot of my patients come in here complaining about other practices that they didn't have good experiences with, knowing that they've heard that they'll have a good experience here, but also my Google reviews and things like that. That's what people tell me that they find me. I don't actually do any advertising. I don't do any marketing. And I'm also happy to kind of see somebody for like a year or two, and then they move on, or they don't need to see me anymore. Because I'm just here. The reason why set this whole thing up is to just get people informed on their health and how their body reacts to things.
Well,
Now,
so
mhm,
keep going.
one thing that you asked earlier, it just reminded me of another patient situation. I had a patient that was literally eating, um, Burger King for breakfast, Wendy's for lunch, and Taco Bell for dinner, literally like 3 times a day. Total cholesterol 157. LDL is like 70s or 80s. And I was researching her, and I was really curious because I'm like, this isn't just, you don't have a familial gene that predisposes you to high cholesterol. There's something else going on. And I ordered a genetic panel for her to see if she has a mutation in certain genes, one of them being PCSK9, which is like what actually is a drug
Yeah.
target for people who have high cholesterol. It's an inhibitor of that drug. But the genetics department said you can't you can't just order a genetic screening for this test for this patient just because her labs are good, and so it's just a funny thing that like happens when I love data, I love information, I love to understand, and but imagine there's some kind of clue that gives you about why she's having abdominal pain all the time or something else, right? And so that's the kind of stuff I also look at, not just when it's bad or trending in the wrong direction, but what's going on here? Why is it not what I would have predicted? And what kind of clue can that give me about that patient's whole body? I'm just a curious person that then can help me understand other things about the patient. She's
Well,
been in a lot of emergency departments for
so
that.
I'm going to postulate something a little bit here, and it's a little bit forming in my brain. So part of the reaction to these tests by both the providers and clinicians who maybe practice secondary and tertiary prevention is you're going to create a whole bunch of false positives, blah blah blah. What if
I've
it
heard that.
really what if it really helps you understand how to do primary prevention?
Yeah. I
What if
love the
it
pulse. Oh, go ahead.
what if it opens up that side of the opportunity? And so that leads to a thing we were thinking about. We've sort of postulated with some others around should we build? And that is, as we've been thinking about AI, we really think about how does it replicate the doctor? Does it increase agency?
Yeah.
So
I love that.
so you get to the point that I am a patient, I now have some more information, and I'm more comfortable understanding what's going in, and I'm more prepared to have a conversation with my clinician closer to their level, not precisely, but familiar enough to better handle it. And so if that's the case, then what you would think about technology wise a bit is, hey, I've got this issue, I've got this concern, and that, you know, I'm trying to get my inflammation down and I don't have non-fatty liver disease. Like, what are the proxies that can help me get feedback? And it's good to sort of say, well, you don't have to get a DEXA scan every day. Get a tape measure out and measure that daily, and then maybe get a DEXA scan every 6 months. So the sort of guideline of sort of saying, not I've taken this test, now what do I do? But I'm trying to achieve this objective. I'm taking the test to get the feedback, and here are the 5 other feedback systems. And now here my care plan is I'm in a primary prevention mode. I've got family history for diabetes or whatever, but I'm A1C 5.2 and I don't want to get over to that other side. What am I going to do as a pre-chronic patient to avoid that? And now here's my care plan, and here are some tools that help me. And then I'm going to go take the function test as a way to feedback
Yeah.
that my plan's okay as a precursor, not as a postcursor, not as a diagnostic, but as a preventative measure. Are you? Are anybody using them as preventative measures? I don't know if I'm defining this
I
well.
definitely do because I'm looking at trends. But
Yeah.
I want to touch on two things that you mentioned. One is the false positives. I really like to discuss this topic because it speaks to the systems. I mean, we were all scientists. We're supposed to be scientists. We're supposed to be information gatherers. So the fact that we have this culture now in medicine where we don't want testing, what happened there? Like, where did that come from? And I think it has to do with the fact that there's been enough situations. Everybody has been in a situation where we've dealt with having to explain a result that seemed positive to somebody um, that they're super anxious about, but you know it's okay, and then you have to explain it to them, but they don't understand your explanation because they're not there in that way. So actually, I think AI can be a huge bridge for this. I think it does a much better job sometimes of like being supportive of people in that way. It
Yeah.
can be sycophantic to the extreme, but it can also just never stop answering your questions and never stop reassuring you if that's the case. I think it does better than Google, right? Because before Google would produce, all the 20 things that could kill you when you
Exactly.
typed in something. And now you can actually say, what are the chances? And it will give you the chance. What
Right.
are you know what I mean? And things like that. And I think it could be really good with AI to kind of mitigate that, hopefully to the end result of people now accepting that people use AI and also that people want information and people want data. So that's the first thing. And the second thing, with that, I've always liked people being more engaged. I love people when they have agency. I love people when they because obviously it makes my job easier as a lifestyle medicine clinician when I'm trying to change behaviors. But there is an aspect of that where you know I also think we can't. There's a very thin line between that and also I want to say like judgment or being too critical of somebody's behaviors and lack of thereof or a lack of self control that led to certain outcomes. And I want to say that like again to my point earlier that like I don't it's great that we're scientists and we can interpret things and we can give the information, but maybe to your point earlier, hand it off to somebody who actually is going to be really great about patient behavior and coaching and mentality,
Yeah.
so that they don't kind of turn the person off from the discussion that you're having with them about their behavior changes. So
Are you are
yeah.
you seeing because you're seeing the advancement of AI over last year?
Oh yeah.
Are you seeing the behavior change, or you're seeing patients come in better prepared to have a conversation?
um let's see. Yes and no. I think like the predictable people who are super engaged in their health are are making all of those changes themselves with better information. I have patients that have figured out their own peptide regimen that I'm not involved in, but they just tell me that they're doing it. I can't like, there's no law against what they're doing, but it's
Right.
good for me to know about it. And so that's only possible with some of the things that have happened now recently with AI, that they can like, really get to like something that has worked for them. And so that's there, but also no, like I think again, some of those people have still it's just like we were talking about buckets earlier. It's just like there were certain people that this has enabled to do more with.
Yeah,
Then there
and
are certain people.
you wouldn't necessarily see them because you
I
have one
can.
selection bias in terms of the kind of patients you see to begin with.
So I want to jump in on this. with some comments because I think this is hitting on exactly a slight differentiation, but nuance of what we're talking about. Um, so Christo responded that I think this is important, so just bear with me, but most people overestimate what they can change in a week and underestimate what they can transform in a year.
Yeah.
Hence, set the right expectations, measure small, manage small, keep it simple. But then, and Mike came back and said, this is very true. We live in a world that we want it now. And then I really like the point that Christo made, which is exactly that's the friction and the choke point. Unrealistic expectations kill progress. We expect too much too soon. When results don't match expectations, motivation fades. Set realistic expectations, measure small, manage small, keep it simple. Consistency compounds. And to some extent, that goes back to Carter, your point about visceral fat. Like, I mean, there are certain indicators, like I, for example, am not you. I would spend 12 hours a day on my mountain bike if you told me I had to without a problem. But I know I need to go to the gym and I just don't love it. and so, and I know it takes time to get muscle mass. Like I've lost a lot of muscle mass in the last year and I know what it takes to get it back. And so it's this whole that small versus big, right? Like incremental versus bigger. Visceral fat is a good example of that. Like you can't lose visceral fat in a day. And you also, it's much more difficult to see that shifting, right? Versus you look in the mirror and there are certain vanity metrics or whatever. Like it is an interesting juxtaposition. And I feel like we're talking about data and having data. I mean, I also want to throw in on the AI front. I've witnessed this is you definitely get to a level. There's like this interesting dynamic. Anybody on here who's gone really deep in AI in whatever, right? I've now seen this weird relationship where like those dopamine receptors are just going off the charts of excitement with what I'm learning and what I can do and where I can go, right? And then it just gets to this point where you're like, and this is what I do. And you're like,
Yeah,
and
I
so
wouldn't
I
know
think
anything
that
about that.
was that. Yeah,
I wouldn't
exactly.
know anything about that.
Exactly. But this is all related. And so I think, I mean, I know I'm getting a little bit esoteric, but it's super important because to me, AI, whether we want it or not, whether it's the clinically sound thing, whatever, AI is now part of our healthcare system. We have
Well,
no
so
choice.
if you recall, back in 2000 when the internet really started taking off, the general premise was there'd be Walmart and there'd be Walmart.com. There'd be two separate businesses.
Yep.
And a lot of companies started creating .com businesses in a fashion that really sounded they were going to be completely different business lines. And by 2010, it was none of that. It just sort of blended in the background. The .com part is a utility. I could buy in store, I could buy online, it became flexible. So I think that likely AI is a utility. It's not Skynet. Maybe it's Skynet, but we don't care if it is. So it's not Skynet, and it's going to be a utility that flows in the background. So then the question is how do we make it a utility faster? And so it's annoying. There are these things, even from the providers. You didn't include my test. You need to have this test, which are true. Those tests should be included, and people are like really particular about these things. But it strikes me the more monumental point is this allows primary prevention to occur in a way that we've never had primary prevention. And if you get primary prevention, then you eliminate chronic disease. And if you eliminate chronic disease, you've just wiped out. I mean, your number's higher. Mine's still 1.9, $2 trillion in the economy, can be reallocated, and healthcare costs for household healthcare costs for insurance for a family of four goes from 32,000 to 20,000, and a whole class of treatment disappears. There are no, you're not having end stage diabetes, CKD, $20,000 a year dialysis going on. And so we can complain about the false positives, but that's like Walmart's going to be its own website separate from Walmart, which isn't the way. The false positives are just we're going to learn from the false positives.
Well,
we're going to learn from the false positives. It is a friction point we're going through. We're going to learn from them. We're going to understand the tacit knowledge of the doctors and the patients to sort of work through this in a way that they understand how to have the conversation differently. But it strikes me it's a totally different thing to teach a clinician to be focused on primary prevention.
Oh, it's totally different. We do not learn that. And it's different questions that we're asking. So I want to say, like, if we tell AI to do what we currently do in medicine, it won't be what you're saying. It won't be, because we're not doing that. The questions that you can ask sometimes are different, right? So like, I look at the liver labs and I know when somebody has been drinking or not. I know when somebody, just everything about it, just even if they're not in the normal range. I know if somebody's been exercising or not, even again, if nothing is abnormal.
Yeah.
So I think, like, you know, nobody's, no, not nobody, but like, because it's not a billing code that you can submit to an insurance company, there's not an incentive to understand those parameters for those things better. But I think it's coming. And like I mentioned earlier about the real world evidence companies, that is what I think is the future. Everyone's own personal labs and history is
Yeah.
going to determine their normal and abnormal, which is it's good. I mean, I think that's a good thing. And I personally am really excited about how this can transform. It's going to be with AI plus a change in mind shift, which is already happening with lifestyle medicine with or without AI. But it's exciting that those are happening together. We
Yeah.
actually
And
also created an AI lifestyle medicine company, so I'm also founder of a company like that. And it's to do what you're saying, is to deliver those kinds of lifestyle recommendations at the
at
place.
scale.
Yeah.
Yeah. And I think it's reasonable to say, for, based on what I know and what's going on in the technology, I think it's reasonable to say that for $100, $200 a year, you'll be able to get the full breadth of assays you need to support primary prevention. The cost of this stuff is going to go down. The ability to proxy it off of other indicators and to build a sort of a real time primary prevention signal database to help guide you is, I mean, we're not talking about something that costs $20,000 a year. We're talking about something that costs $100 or $200 a year.
yes.
And avoids $10,000 a year healthcare costs at scale.
Well,
Oh,
more than
For
that,
family of four.
more than that, Carter, it actually solves for an access issue and a setting of care issue.
yeah. That's how we position ourselves, is the access, enabling lifestyle care in every clinical setting.
So
Exactly.
to expand on that,
Me.
Oh,
anybody can do it.
so when I started lifestyle medicine, I'm super tech forward, and I was looking for problems to that clinicians, because I talk to a lot of clinicians and they all love lifestyle care. They just can't do it, right? So what are their pain points, right? What's the issues? And I started with information gathering. That was a dead end, but it turns, like, with every time, wherever you start, you're going to learn something. You're going to have the conversations. You're going to keep talking to people, and it's going to point you in the right direction. So what we have now is it's like a prescription pad that has this, it addresses like a friction point for the clinician, that when a patient comes to them and says, is this pill the only thing that I can do? Isn't there anything else? The clinician then can just take off one of these prescription items, give it to the patient, and it has a QR code that says, and at the top it says something like, you prefer to avoid taking your medications, or the natural approach. I mean, people can adjust the terminology to fit their style, directly from our website. They can customize it. and then it gives them a QR code. The patient can just use that, and it links them to an AI agent that's a lifestyle care agent. So all of a sudden, now everybody has lifestyle care. I wrote the guidebook to ACE the Lifestyle Medicine Board, so it's basically all evidence based. Everyone, there's citations, it's reviewed, every single recommendation is reviewed. So it's something that clinicians can trust and validate, and then feel safe handing to their patients, because it's not going to say something like, drink your urine or something like that, which patients
Yeah.
have told us they do. And so it's never going to say something. They can't really, as a clinician, I can't really tell my patient to try using ChatGPT and see what it comes up with, and then come back to me. You can't do that because you don't know what it's going to say.
Yeah.
But with this, like, you can know what it's going to say, and it's gonna hopefully, I would expect, like, 50% of the people to engage with it, and then 10% of the patients to actually do the things at the level, and maybe 20% more to do it at a subpar level, but still be healthier because they took a step in that direction. But it's 30% more people that are doing it than weren't doing it before. So I think to your point, I don't think it's going to ever eliminate that whole category of care, because I don't think, like, as a human population, we don't have a great track record of just doing everything that's good for us all the time.
Yeah.
But I do think that we can make some progress here. We can move the needle a little bit.
Cool.
Yeah.
So, Carter, do you have a few minutes to stay on and dive into the post a little bit more?
I do. I'm
Okay.
running out of time. I've probably got 10 more minutes, and I've got one. I gotta get a wire out.
And
Okay.
I can let you guys go. I'm gonna go pick up my kids. But it was so good to chat with you.
Yeah, and
Yeah,
hopefully
thank you for.
we'll chat again. I mean, I
Okay.
don't want this to be the only time. I
No,
appreciate
no.
you being game of jumping on in the last minute.
I appreciate you having these discussions and, exposing us and being vulnerable with your posts. I mean, I think you've dealt with a lot of pushback, and I think it's great that you're opening up these conversations so that everybody can start talking about it. I love it. So thank you for everything that you're doing.
You're welcome. You're
So,
welcome.
thank you. All right.
Okay. Thank you. You have a good one. All right. So we've got 5 minutes, right?
Yep.
What do we want to do in 5 minutes? What can we do in 5 minutes?
I guess we could figure out what we just said.
Well, that seems redundant.
Well, so what we are doing a little bit, so we'll expose this a little bit more. Our Cressonia.io website is starting to gather this stuff up. We have assembled, we're starting to realize we're having these conversations around data. So we're creating, in the research section, the public side of that website, we're creating a research section that has sort of interactive reports. And we put this up sort of as a demo, your chart, and lets people sort of move through it. I would be interesting, I think, I'd be interested in creating a tool for people that they, based on this, is I'm coming down this primary pathway, and I want to figure out what tests might be able to give me the feedback. Instead of saying, I want to see if I have cancer, say, what should I be doing? What tests should I do so I can avoid getting diabetes?
So that's Josh. So Josh said, also for your chart, it would be fun to connect those markers to validated measures of aging and other aspects of validated predictive models and availability in federal and global cohort studies. We were doing some work with NIUM on that front. Maybe a way to collaborate if you were thinking about continuing to develop it.
Yeah, I would like to. I would be really interesting, because ultimately the end goal here is get rid of chronic disease. That means we have to overexpress primary prevention. I know we think about secondary and tertiary prevention, and we want to be able to get people back. But I think that if we focus on primary prevention, and what blood tests help you manage primary prevention, I think we all of a sudden start getting into a really interesting area of empowering people to do that. And then we get the proof points. And then with those proof points, we get positive externalities that cause better decisions. That's what.
So,
And
and we
what
also want
tools?
people, and we want people to go to Crestonia and sign in and create profiles that we want.
No, they don't need to do that. I think we should be thinking we got to put these links out there a little bit. But I'd
Well,
be
I've got,
interested. What can we do in those interactive reports to give people better information about what they should be doing next?
yes,
That's
and
sort
these are I mean, I'm showing right now the screen of the existing interactive reports that are on there. So
So anyway, that's one interesting thought that I have.
okay, there's lots of thoughts, lots more to talk about on this one. I think we'll probably end up talking more next week because we didn't really dive into the debate area of this. And
Well, we've been on this for 2.5 hours.
No, an hour and a half.
Hour and a half. Still, an hour and a half is pretty long for one of these things, but it's good. Well, that was great. How did that happen? How did she just jump in?
She jumped in. This is how it happened, was right here. I'll show you because this is how.
Oh, she was talking and you threw her on. That was neat.
No, it wasn't that. It was a little bit more coordinated than that.
Okay.
Not quite. I mean, not much more, which was, so she jumped into the dialogue yesterday. But I really appreciate her perspective. This was her response. This is almost exactly what I get on my patients, especially as an initial set. I don't get uric acid and everything under other unless it's otherwise indicated. So I said, thanks for sharing. I'm curious of what you think about the comments above. And then she said this. I just thought this was fantastic. I don't just look at normal and abnormal, but also trends. So ferritin today, even when you don't have any complaints, might be 70, but tomorrow you might be fatigued and it's 20, maybe just above abnormal, or even labs like CBC. White blood cell count for some people is baseline 4.5. So doubling is actually significant for them, but would still fall in the normal range as per lab results. So this is the whole reference range debate. And she's a big supporter of personalized, right? On my personal labs, I was able to see how increased cheese. She talked about this. She talked about sensitivity for trending platelets and how a patient had changed when they stopped drinking tonic water and their fatigue resolved. I mean, those are, and I think that's what I loved about her comments and why I wanted her on was she's a clinician and she's chosen to embrace the data and she's chosen to figure out how to make it personalized in a healthcare economic model that is not supportive of personalized medicine. And I think it's super important. I think it's important to hear how clinicians do that. Of course, then I said, well, I want you to be my doctor, but that's for another day.
Okay. I have to go.
Okay. You have a good weekend, Carter. And for everyone joining us.
I'm sure.
Wait, I'm going to shut it down with Christo's comment. Isn't the best way to prevent chronic disease to not enter a grocery store? In today's grocery store configuration, yes, but in the Sytem C configuration, the grocery store will no longer be a place of bad decisions. So There you go.
Okay. Bye.
Okay. Bye.